To welcome us to the Rotman School of Management, I would like to welcome Brian Golden.
Okay, I obviously have students in the room. So I just want to thank everyone for joining us at the Rotman School again. This is, I think, our second event with Longwoods just this month. And we're always pleased to have our friends and new friends join us, whether in the room or virtually. And I know we have a significant number of folks virtually. And especially happy to be hosting a talk around AI. AI figures prominently in the work we do at the Rotman School and prominent in our Global Executive MBA for Healthcare and Life Sciences. So it's a pleasure always being able to host the most cutting edge topics with great friends of the school and Longwoods. So I'm going to turn it over to Matt to introduce our speakers and then let the show begin.
I would like to welcome Helen Angus and Matthew Hackenberg.
Thank you very much. And just to add, we were also joined very incognito in a bright green jacket by Deborah Richardson, the current Deputy Minister of Health. So you missed out also on being able to spend some time with her, which is always a pleasure. So thank you again for joining us here, both in person and online. I'm really looking forward to hearing from Matthew and the work that he and IQVIA is supporting. I am now the CEO of AMS Healthcare. And if you don't know us, our mission is to advance innovative healthcare with compassion at its core. So I will be asking a few questions related to the human aspects of delivering care. We are active in developing leaders grounded in compassionate care with 2 streams of leadership development programs in AI and compassion. And I was delighted this morning to meet one of our incoming fellows who's also here in the room. So they're terrific people, and they are on their way to doing fantastic things in the health system. So about AI in healthcare. We know that AI innovations are poised to transform healthcare by enhancing human capabilities. They promise to improve diagnostics, to advance the speed and output of research. They have the potential to boost patient engagement and streamline administrative tasks, and thereby, we hope, elevating the quality of care and the provider experience. The challenge that we're tackling at AMS is how do we scale these advancements while maintaining the human touch in patient care? In Ontario, we're going to hear some examples from the US, but Ontario also stands out as a leader in AI technology with a myriad of AI point solutions which are actively used in healthcare research institutions across the province. And in fact, I'm on the board of one that has 53, I think as of last November, anyway, 53 unique installations of AI in production right now. Despite these advancements, many solutions are confined to smaller project-specific applications. And our goal is to drive widespread adoption across Ontario's broader healthcare system. And that goes hospitals and beyond into primary care, into community care and other settings. So we'll be talking a little bit about that as well. So we held a conference in May. We have an annual conference. The consensus, and AI was the topic. The consensus there was that there was an urgent need to deploy AI solutions in some of the most capacity challenged areas of our healthcare system, and particularly in primary care. And this move, we believe, is crucial to reducing workforce burnout and improving workflows in a part of the system that really needs to work better for patients. So the summary of the output of that conference will be posted on our website today and includes a whole bunch of ideas about how to responsibly scale AI in healthcare in Ontario. And I'm happy to be talking about that a bit later. But right now, I'm going to turn it over to Matt and look forward to your presentation.
Great. Thank you.
Can everybody hear me? I'm a bit of a walker, a roamer. Okay, great, fantastic. Well, thank you, Helen, very much. I'm in awe of the talent and the experience in this room. So I will share knowledge today, but I think I could just as easily be sitting in the audience and learning a lot from this group. When my colleagues from IQVIA asked me if I would be interested in coming to do this presentation today, of course I jumped on it just because I think that the Canadian health system has many parallels to the US healthcare system. but also any opportunity to come and visit the Canadian Tire store is a great reason for me to make the trip across the border. So today, what I'm going to focus on is what I refer to as practical applications of artificial intelligence in clinical workflow. And that's really focusing on clinical decision support tools. So if you're familiar with AI, the umbrella of all of the capabilities is quite large. When you think about large language models, generative AI, machine learning, natural language processing, a lot of the work that IQVIA does is in all of these spaces. But for me specifically, as a clinician, and I'll give you my resume here in a minute, it's important for us to identify opportunities to deploy these predictive insights into clinical workflow for clinicians to take action. So that'll be the crux of what I want to talk about today. So by a show of hands, my first question from at least the group here is, who's familiar with IQVIA? As I would expect, maybe 10%. I had not heard of IQVIA when I was first attracted by a recruiter to come on board. And I could say that IQVIA is probably one of the largest data science organizations that supports the healthcare sector that a lot of folks have not heard of or are not familiar. So our clients are healthcare organizations, pharma, life science organizations, payers, et cetera. But the depth and the size of our organization is just incredible. So we're talking about a global organization, 87,000 employees, a presence here in Canada, obviously the US and the rest of the world, 2,000 PhDs. Great thing for me as a clinician is the ability to tap on the shoulder of a physician as part of our center of excellence. And that's over 1,850 clinicians, physicians, medical doctors, that if there's a clinical area of interest, you can generally find somebody that has experience in that space. And it's easy for any team member within IQVIA to tap that person on the shoulder. But we've got robust data sets, over 1 billion medical records related to patients. They're de-identified, so we don't know who those patients are. But the value of having such a robust data set for us is the ability to develop analytics and these AI models, because one of the caveats or the core tenets of building an AI model is building on such a large data set that it's representative of wherever you deploy it at. So it accounts for bias, health equity, social determinant considerations, and things like that. So who are we? Who's our team and who am I? I'm a registered nurse and an informatician. I've been practicing informatics for about 17 years. And I did a fellowship with the National Library of Medicine in the US in biomedical informatics about 17 years ago. And I've been practicing it ever since. So I did some clinical work in my early stages, but I knew that data and analytics was the future of healthcare. So if anybody's familiar with Geisinger Health System in central Pennsylvania, I spent a decade at Geisinger Health System as the head informatician for the system, but also I led the Care Gaps and Best Practice program for several years. And that team in that program was really designed around identifying clinical gaps or care gaps in care and deploying those into clinical workflow for clinicians to take action on. So very, very similar to what we're doing here with IQVIA today. The difference being we were focusing on rules-based analytics then and not so much in the AI space. But our group, the AI for Healthcare and MedTech team, was spun off from a larger AI team about 4 years ago or so. And the goal was to take all of this robust knowledge around artificial intelligence and the building of machine learning models that identify patients and clinical pathways, patient journeys, and identifying if a patient is going to progress into disease, who are they likely to see as a provider and things like that. The gap to be closed and the core mission of our group was to address that gap from generation of evidence to deploying it directly into workflow for clinicians. And that's what our core goal is at the end of the day. So we're looking for things that are sustainable, that address change in healthcare, but also looking where we can support providers, payers, nonprofits, government organizations, and life sciences. And before I jump from this slide, one key point here is that the current state of healthcare, at least in the US, organizations have razor thin margins, right? So the idea of investing in any kind of analytic is a challenge. I can tell you countless times that I've gone to speak with clinicians around a given artificial intelligence algorithm that identifies a rare disease or patients that are likely to progress. And the clinicians are all nodding their head in the room. This is a great thing. But the barrier is with the IT side of things and also with the financials. So one of our key goals as a team is to close that gap to deliver the insights, but to also see where we can leverage funding opportunities external and bring it to the organization in a compliant way. So that could mean life science organizations sponsoring the development of an algorithm, the government. And I've got a couple of case studies, examples that I can talk about in this space. So I apologize in advance. All of my images didn't quite translate over when we copied over the deck. So I will make sure that we have a good clean one when we send it out. But what makes us successful in the AI space at IQVIA, and I think it is the fact that we're a smaller, scrappy startup group, almost like a skunk works within this large global organization. And we pride ourselves on a couple of different things, right? Having a thorough understanding of the regulatory environment, privacy, compliance frameworks, because one of the first questions or first discussions that we always have working with a new client is what's your data governance, what's your data strategy at the end of the day. But there's also UI and technology. So we follow modern UI UX principles for user-friendly design. We have a multitude of integration methodologies to integrate our solutions into clinical workflow. I have a preferred one, Smart on Fire, which I'll talk about in a little bit. And then the clinical aspect. So we've got at our feet the specialty physicians in our Center of Excellence, implementation science methodologies, and my experience as an informatician doing this type of implementation. From an analytics perspective, countless data scientists. We have award-winning NLP methodologies, custom software kits for getting access to data and developing predictive algorithms on it. And knowledge and experience, 20 plus years of developing predictive algorithms and working with clinicians. So what are we up against in healthcare? I think that we're seeing slow, steady progress, but there are challenges with implementing. And despite that early progress, there's some barriers that I think remain to full-scaled adoption that we can show reflect a positive impact on healthcare. So thinking about the development cycle, looking at this slide from left to right, in the early stages, what are the challenges we're up against? Is this voodoo of AI? AI is going to take away my job. AI is going to tell me things that are inaccurate, and AI has hallucinations, for instance. The funding piece, having the resources and the funding to actually build out these predictive tools. Algorithm development and the data challenges. I can't underscore the data challenge piece enough. I can say from my experience in the US that you may have multiple organizations that are using the very same EMR, but their underlying data quality can be very different. Some really good organizations that are great at using ICD, standard coding tools, Snowben, things like that. Other organizations have the exact same EMR and their data is a mess. And I think this is one of the biggest challenges that we face. And it's a barrier for us to do really good machine learning in the long term. So we have to have methodologies to get access to this data, but also standardize it. And that includes the unstructured data. We know that 80% of medical data is in unstructured notes. So what's a process that we can have in place to gain access to that, align it to structured content, and then be able to use it within these algorithms? Data privacy and security, especially in the world of the generative AI and LLM space. I feel like it's very easy for somebody to take a lot of PHI, put it in one of these tools, and the next thing you know, it's available in the public. And it's a real concern, and there has to be good protocols in place for that. Algorithm testing and refinement, so showing the proof of effectiveness. You cannot just take a black box algorithm that you've developed and throw it into a production phase and have clinicians go at it. It has to be validated. There's always going to be some tweaks, and some of the pitfalls with data that I mentioned are things that need to be ironed out as you move on. Interpretability and transparency. One of the caveats for any AI that we deploy is that it has to be interpretable for the end user, and it has to be transparent in terms of what was used to develop the algorithm. So if any clinician wants to understand What data did you use to predict that Matt Hackenberg was going to have a stroke in the next 3 months? They should have clear access to it, not that it has to be invasive in the UI, but clear access that they can go and review that information as time goes on. And then for the sweet spot for me, this last piece is disseminating the findings in the workflow integration. I cannot underline this enough, that you could have the most elegant predictive algorithm that is highly accurate, but if you're asking clinicians to do something that is outside of their normal workflow, it will struggle for adoption and it will struggle for stickiness. So our philosophy is get it integrated directly into clinical workflow wherever possible. And I'll talk a little bit more about that. So what's the promise of AI in healthcare? There are actionable use cases where we can deploy clinical decision support tools, and these are machine learning-based clinical decision support tools. And ultimately, with machine learning, you're consuming copious amounts of data to do one thing, to identify the signal above all of the noise. If a clinician had to review a patient's chart from end to end, there's just too much information that's in there. So the value of machine learning is to be able to look at a particular audience. Let's say I wanted to identify adults that were going to develop type 2 diabetes in the next 6 months. I would look at that known population and all of the data that's around them and be able to stratify what are the main drivers, what are the key themes amongst that population that make them highly likely to develop type 2 diabetes. And then once we develop that algorithm, we apply it to an unknown data set. And then you look for the similar, the tea leaves, basically. You're looking for very similar patients to your positive population to say, hey, there's a patient in here that is very similar to somebody that developed type 2 diabetes in the future. You might want to do something about that. And that's our strategy and our methodology to develop these algorithms and deploy. So the promise of AI, definitely disease detection. So where can we identify patients that are at risk for developing a disease, somebody that is underdiagnosed, likely for developing a condition at some point in the future? We're working on a predictive algorithm right now of identifying patients in Saudi Arabia that are likely to develop a stroke in the next 3 months so that the care team can intervene. Next opportunity is patient adherence. I think this is an important one, but this is challenging in terms of the data necessary to really reflect adherence. It requires having access to things like fill data, how often the patient's getting their prescriptions filled, maybe even some patient-reported data to say, yes, I'm taking my medication. So there's good data to identify where there's a risk for adherence. It's definitely aligned to certain existing chronic diseases, but having a good sense of who's likely to be at risk for non-adherence is a great opportunity. One of the struggles that hopefully gets solved as time goes on and we get better at things like natural language processing and LLMs is understanding some of the patient direct data that drives non-adherence. Disease progression is another area of interest. So where can we identify somebody that's likely to progress in a disease? It can be anything that you can imagine, the cancer space and so forth. A great opportunity. And the goal here is, as you can translate, is to predict these things before they happen and get them deployed for the right care team member to intervene before that bad thing happens. Adverse event management. Adverse event management can be a lot of things, thinking about patients that are going to have an adverse event based on a proposed treatment that they're going to have, somebody that's likely to end up in the emergency department or urgent care because of a condition. Very similar to the next one, hospital readmission. So who's likely that's going to be readmitted to the hospital post-discharge for the care team to review before the patient actually goes home. And there's generally common themes around why these patients tend to come back in. A lot of it's driven by social determinants. So if we're able to identify these things beforehand, the goal would be to address those drivers of the readmission and prevent it from happening at the end of the day. And then the last one on the list, treatment response. So this gets us in the space of precision medicine. This is probably the hardest of all to do because it's very patient unique. So to generate a predictive algorithm that identifies a risk for a future event, allows you to use copious amounts of general patient data, but when it gets into the treatment response, you have to understand a bit more nuance about a patient, their genetic makeup, specific serum biomarkers and things like that. Not to say that it can't be done. It has been done, and we have a couple of examples of doing this, but it's probably the most challenging out of all of these. So at a high level, where do we think that we can have the most or the highest level of impact in healthcare using these machine learning predictive algorithms? First and foremost, identifying patients that have clinical gaps in care. In the context that I'm going to use today is talking about where there's an opportunity that a patient hasn't been aligned to whatever is best practice for managing a disease. So I'll use the diabetes theme throughout the morning here. Think about a type 2 diabetic patient who hasn't had their hemoglobin A1C done in the last 13 or 14 months. That, if we're able to identify in the data, is a care gap in itself. But also a patient who, let's say, has not yet been diagnosed with type 2 diabetes. What's the care gap to be done? It's the blood work, it's the hemoglobin A1C, and so forth. So the goal is to make every care gap that we put in front of a clinician actionable. That's the key. It can't be something that's just informational, because nobody will ever have a good sense of, am I supposed to do something with this? What do you want me to, how do you want me to take this information? So actionable is key. Facilitate the choice of clinical and social interventions. So this requires, I think, more of the NLP, natural language processing space, but trying to tease out in clinical notes, notes from social workers, where are those underlying drivers of health equity, social determinants? Somebody has food insecurity or they live alone, and being able to escalate or elevate that to a clinician, because the social safety nets that are available continue to grow. I would say 10 years ago, this was a real challenge, but we're starting to see opportunities where we can engage these patients in these solutions. Prioritize patients by risk of negative outcomes, provide insight into patient and clinician behavior, and surface data hidden in the patient's medical record or other opportunities. The goal for us would be to, again, looking on the right-hand side here, align to clinical guidelines wherever possible, reduce the overall healthcare costs. It's a little bit of a challenge, I would say, in the US at least, where we're still heavily driven by fee-for-service. So these predictive opportunities where we're looking to prevent an event before it happens is not as incentivized as letting the event happen and then being able to treat the patient and all the downstream. So we need to get into this paradigm shift where the focus is on preventing those bad things from happening. It's, I think, going to be a long-term haul between healthcare organizations and payers. So what is it that we do? We develop clinical decision support tools. And the goal for us would be to understand the clinical care gaps across the patient's journey as it relates to any specific disease. So all of the care gaps are the opportunities that I mentioned before: disease detection, progression of disease, appropriate treatment. The goal is that the provider is always the end user, or the care team. More importantly, it doesn't always need to be the provider. But we try whenever, as I mentioned, look for funding from life science organizations, government organizations, and nonprofits at the end of the day. One of the caveats that I bring to the work is identifying opportunities to align the care gaps with the right care team members. A philosophy that I bring with me from my Geisinger days is that there's no reason that we can't ask and drive the other care team members in let's say, a primary care practice to work at the top of their license. Provider burnout is a real thing. Alert fatigue is a real thing. There's not enough clinicians to go around. We're not in a situation where we can continue to have clinicians shoulder the burden of managing all of this information and all this data. So our philosophy, or our methodology of understanding current state and future state workflow, is figuring out how the patient navigates through the health system and ensuring that our insights are deployed directly into the workflow for those team members so that they can decant as much of that responsibility away from the primary care physician or the specialist. And the last piece is, we're not a sole AI machine learning team. Hybrid rules-based analytics, I think, complement AI models. So our goal is to develop the concept of care bundles. What is everything that needs to happen with a patient with a given disease? and align all of those care gaps with what's best practice. I'll use asthma as an example. Asthma patients should have spirometry on a regular basis. And the national or global guidelines are GINA guidelines, right? Patients should be on some form of maintenance or reliever therapy when it comes to asthma. So taking the data, and this doesn't require a predictive nature, taking the data to identify where those patients aren't aligned to that best practice guideline. It helps us with adoption because providers can't necessarily push back against what's the well-known established standard. But then surrounding that with predictive elements. So it's more than just understanding who the asthmatic patients are in a clinic that aren't up to par in terms of best management, best treatment. Why don't we also take out of that subcohort who's likely to have an exacerbation in the next 3 months, the next 6 months? So that the care team, as they're working with this patient, they're looking at a 360-degree view of everything that IQVIA knows about them. It's not just about one single thing that they need to address. Take advantage of the FaceTime with the patient and make sure that, that you're addressing as much as you can. We do have a case study here that I actually have a deep dive slide on around predicting strokes in AFib patients. I'll skip over that, time permitting. Did I lose my, there we go. I think I'm good. Sorry, Matt. So some examples, real world examples of projects that we've developed. This first one, we have colleagues in the UK working with NICE guidelines and the NHS, where they've gone out and they've identified for many GP practices patients with AFib that are at risk of developing a stroke. And from applying those analytics and working with the clinic staff, they saw a 22% reduction in overall risk for stroke post-implementation. And that translates to roughly $7 million in cost reduction between the clinical cost and the time off work and the family associated issues. The second one, I have a deep dive into this. This is working with a nonprofit organization, formerly JDRF, new name. JDRF is Juvenile Diabetes Research Foundation. And this is identifying adult patients that are misdiagnosed with type 2 diabetes when in fact they have autoimmune disease and they're type 1. When I first saw this as an opportunity, I kind of shook my head and said, this probably rarely happens, but you'd be surprised at how often adults are diagnosed with type 2 and how long they go until they get to the correct diagnosis. But I have a deep dive into this as well. Next one is identifying patients with undiagnosed hepatitis C. This was sponsored by a pharma organization, and the idea was where could we intervene before these patients had a flare-up, before they develop longer chronic liver complications. Another example is servicing hidden social determinants. So this won us the Best in Class AI award for working with a healthcare system in the Midwest, applying natural language processing to EMR data, where we were looking for specific social determinant risk factors, one of them being physical abuse, home abuse. And a simple integration, not an elegant integration, I would say at the end of the day, but the audience in this case was in the emergency department, social workers, so they'd be able to see the information if it was identified by the natural language processing anywhere in the medical record, and then be able to intervene with that patient before they were discharged from the ED. Another example is working with the CDC in the US on an antibiotic stewardship program. So trying to understand in the space of acute respiratory infections, why are so many patients getting prescribed antibiotics when it's not appropriate? Acute bronchitis, antibiotics are not appropriate. So taking a deep dive, looking at national claims data, identifying what the drivers are. And as it turns out, this most often happens in urgent care ED clinics, and it happens with advanced practitioners, not necessarily with physicians. And if you could hypothesize what the situation is, somebody's coming in on the weekend, they're not seeing their primary care physician, they're saying, hey, I've got this issue, I'm hoping, the perception is if I go to see the doctor, I hope to get an antibiotic. And advanced practitioners don't necessarily push back on that. So that's why some of those prescribing habits occur. I can tell you there's a lot more to this. There's a lot more detail as to the history behind how long the patient was suffering. that that we're interested in exploring further, because providers shouldn't necessarily get dinged at the end of the day for doing the wrong thing if the evidence is in the EMR that they ask the right questions, but it still tends to be a challenge. And then the last one is another one from the UK, 26% increase in patients with all 9 NICE recommended care processes for a disease. Our team overall has developed over 150 predictive algorithms over the last 10 years. We've been working in the disease space for 20 plus years. I'll go pretty quick through this. I think I've highlighted this, but algorithms don't necessarily have to be applied for large patient cohorts. So if you're looking for a broad disease like type 2 diabetes, it's great for predictive algorithms. But very rare diseases are also lend themselves to predictive algorithms. Our cutoff, we like to say, is you want to find about 200 patients and not less than that in order to have an algorithm that is highly predictive at the end of the day. So it doesn't require a large patient set. But any of our algorithms can be developed on both structured and unstructured data. I'd say that the unstructured data is where the gold is, just having practiced as a nurse for many years. There's lots of information out there, and any time that we have an opportunity to deploy machine learning algorithms, our preference is to do it combined structured data and the unstructured, because the unstructured tends to tell a very different story in certain patient cases. So I'm going to shift now into how do we make it happen? How do we get clinicians to actually have some interest in this? I don't know, 3 or 4 inches taller when I first started doing this, so I've been beat down over the years. Not so gray at the time, but there's a path forward to do this. And these are workflow principles that I had in my early days, my career before IQVIA, but also bring forward. And it resonates. So what are we looking to do? Eliminate the activities that are non-value add. Key phrase that I'm always listening for is, we've always done it this way. If I hear that, that is a direct opportunity to sit down in a room and talk to somebody, because you will find that there is no reason to do that work, and a great opportunity to introduce innovative thinking at the end of the day. Automating processes. So I think of a relevant ideas, natural language, large language models and generative AI, where we can automate process. Think about how you can generate patient letters today, or take patient letters and translate them into other languages. That's a great example of how you can automate the process. Delegate, to me, this is about having folks work at the top of their license. So who are the team members that can do the job just as well, or maybe tee it up for the physician? EMRs make it easy to say, I'm going to send something to the doctor. All they have to do is sign it. So wherever we can, delegate away from the physician being the primary responsible person. Incorporate new workflows into the provider practice, understand how they interact with patients today, hardwired into existing tools, try to avoid asking them to do new tasks, hey, generate a new letter, do something new. If you introduce something new, see where you can take something away at the end of the day. Activate the patient with EMR core functions wherever possible, and communicate. I can tell you one of the first things that I ask for whenever I go into a new opportunity is, who's the clinician champion? If you don't have a designated clinician champion for the AI, and it can be the same person, AI and the clinical area, or 2 different people, you'll struggle. You'll struggle with adoption. The challenge is having somebody that is boots on the ground, that the rest of the organization looks to as the leader, and making sure that folks are following up on what they're doing, and they're helping to guide good design with the mindset, I understand how my organization works. If it's Matt Hackenberg going in telling somebody how to do it, I'll fail 9 times out of 10. So what are the tenets of deployment methodology for us? Establishing trust. We put bad data in front of a clinician, I've lost them. So if we put data in front of a clinician, we want to make darn sure that it is accurate. And if we're unsure about it, we set the context for that. We need some help here to understand if we're doing this right, and engage the clinicians as part of the decision makers. Learning from our partners. If we make a mistake, we need the ability to rapidly course correct and fix things. The worst thing that we could do is know that something isn't working, and then clinicians start to build workarounds, or they ignore things because we say we can't fix it for a release 6 months down the road. Fix it right away and get them using it. Leverage care team members. I think I beat that one to death. Consistent user experience. So no matter who is reviewing the information in the EMR, if I put a predictive algorithm detail that says Matt Hackenberg is at risk for developing type 2, every team member should see the same thing. I don't want different messaging for a provider versus a nurse versus somebody else. Consistent user experience overall. Be sensitive to alert fatigue. Empathy goes a long way. Going in and asking somebody to do something new or something different goes much better when you're empathetic to what they're up against today. Agile approach, and I mentioned this before, actionable care gaps. So the approach to solution adoption for us to make sure it's sustainable and sticky at the end of the day is to understand what the current state workflow is, going out, interviewing care team members. How do you interact with these patients today? Who all is involved with them? Understand the nuance of how they flow through the clinic. And that's not just physical presence in the clinic, what happens between visits at the end of the day. The next logical step is identify who those care team members are and start to put together who are the folks that we think, when we map out what the future state workflow is, who are the folks that should be working with these patients, and then map out the current state workflow and the future state and do that gap analysis to say, here's where you are, here's where we want you to go. These are the things that need to change at the end of the day. And a key piece that I think gets lost in the mix is also understanding the EMR infrastructure. Where do you need to build tools to support this within the EMR? So if I'm asking somebody to do a set of follow-up care gaps for patients that have asthma, for instance, where's the asthma order set at the end of the day that all that information exists within the EMR, or help them build it so there's discrete capture that they all did the right thing. Future state workflow, we have that. At the end of the day, we've got good design. It's intuitive to the end user, and ideally it has limited physician impact. Am I running out of time? 5 minutes? Okay. I'll be quick. So two approaches to deploying these insights in the clinical workflow. You need to have a patient level view, which means I'm in the context of the medical record and I can see Matt Hackenberg as a patient, right? I'm in Matt's chart. Maybe I'm sitting across from Matt Hackenberg and I want to see the detail that the analytic has, but I also want to be able to navigate in the EMR to see other things that may be relevant. So that's one level. The second level is population view. You have to assume that patients that have the risk of whatever event that we're deploying don't have upcoming appointments, right? Or maybe they no-show for their visits. You need to be able to identify who those patients are in the overall population and risk stratify so that you can engage team members to take whatever action is appropriate. Is it a phone call? Is it calling the patient to bring them in? So our philosophy is we need two approaches to identifying the patients, the population view and the patient level view. Workflow integration. Now, I'm not saying that having a dashboard that is adjunct to the EMR is a bad thing. In some cases, it works well. But the road to success for us is having something that is deployed directly into the clinical workflow. And the technology exists to do this. So for us, on the US side of things, Smart on Fire is an interoperability standard that all organizations are required to adopt. EMR vendors are required to provide this service. And the value of Smart on Fire means that all of the data, all these APIs are mapped. So I can trust that a diagnosis of diabetes from hospital A is mapped the same way as a diabetes diagnosis from every other hospital that we work with. So it solves that underlying data mapping piece. But secondary is it allows us to deploy directly into the clinical workflow. So there's this concept in one of the EMRs where you can frame our information directly in the EMR as a tab. Providers, when they interact with this, they have no idea they're looking at outside data or our information. They just think it's part of the workflow. And that's how you get to the adoption, because you train to going to the tab versus requiring some form of invasive pop-up to say, stop what you're doing, go look here. If you train to, this is the process, this is the workflow, clinicians can build up trust in it. So Couple of case studies. I'll be really quick. This is the one with JDRF, the Juvenile Diabetes Research Foundation, which is now Breakthrough T1D. This was identifying those adult patients, type 2 diabetes, that are likely misdiagnosed. We're in process of deploying this across 3 health systems in the US to validate with endocrinologists, with the intent that we show the value for this and then inform clinical guidelines moving forward as to how adult patients may need to be screened for type 1 diabetes if we can establish there's a specific phenotype. Surface hidden SDOH risk factors. I talked about this. This was the use case in the emergency department with a social worker. I can say that the big number that they take away from here is 56% more patients were screened for social determinant needs. And in particular, they had one patient where there was mention of domestic violence in a note from several months prior that would have gone overlooked, but the natural language processing was able to identify it. And the social worker saw that and was able to engage that patient in services. And this is the last case study, and I'm done. This is an example of identifying the stroke patients. So AFib patients that were not optimally treated with anticoagulant therapy. It's hard to believe, but there were some patients with AFib that weren't on any anticoag therapy. So identifying them in the data and then working with the GP practices to meet with those patients and then assess and make recommendations. And so I think we already talked about the financial impact. So sorry going through that fast, but we could do this for 8 hours and still not have enough time. So thank you.
So I assume we have some questions on Slido, but I'm going to take the opportunity, as promised, to talk about, this looks amazing, right? And certainly, the promise is enormous. And you've talked quite a bit about, how to work with clinicians and make sure that it actually, functions well within the context of the delivery system. I guess one of my questions is, how transparent is all of this to patients? And if yes, how do you build confidence with patients when their, care is being supported by an AI tool? And do you have any best practices on patient engagement from all this work?
Yeah, that really, really good question. I'd say that we're still in the nascent stages of figuring out how to engage patients directly with AI. But what I can say, the goal or the challenge of building trust with patients is they use AI today in their regular lives, just not related in healthcare. If they're using Netflix or, Amazon or something like that, they may not realize it, but
That's how
algorithms
it
are at
works,
play.
eh?
Yeah,
Oh.
exactly. So I've been, thinking about it. What patients do is generally follow what their clinician does and their clinician's recommendations. So the goal or the to get patients to have trust in trust in AI algorithms, I think, is for us to have the trust and reflect the trust in the clinicians that are using it. So if I see my doctor is using the AI within EMR as part of a shared decision-making visit, if they can reflect that they trust the algorithm, I think patients will adopt quicker and be more apt to align with it.
And then I guess, the other area of interest, particularly for AMS, is, do you have any examples in the case studies that you've done where you've looked at what the human experience is of receiving care in an AI-rich environment? Are there things that go along with it? Maybe it's, if you look at release time to care, or other things that might actually enhance the patient-provider relationship.
Yes. So as part of what I was mentioning, where we do the current state workflow, it's one thing, it's actually a gap in what we do today. We don't necessarily bring patients in for the conversation, and I think that's something we could be better at. But the idea is sitting down with the care team members and mapping out what happens with patients today and figuring out where can we interject and where can we take advantage of the tools within the EMR to engage those patients directly. But to your point, I think it's an area that needs more work.
And certainly in my travels, there's been quite a lot of interest. Particularly, I was interested in your number of 200, right? as kind
Yes.
of the minimum feasible set to be able to sort of look into and develop AI supports for. And certainly in my travels, some of the organizations around rare diseases are very excited about the promise of AI. They think that it has the potential to speed up time to diagnoses and other things. So you may find that there are some quite receptive patient audiences and patient partners.
I believe
the
that.
work.
I believe that it's definitely in the rare disease space, or patients that patients, let's say, that have been diagnosed with a rare disease that there is no treatment, or the treatment options are very limited. Anytime that you can introduce an opportunity to say, hey, there's a new molecule that's in the market, we're looking to use AI to identify patients that are eligible for clinical trials, I think generates quite a bit of enthusiasm.
Great. I'm just going to see whether there's questions from Slido. Otherwise, I'm going to keep going. Okay. Yeah, just interested
Okay.
in the time investment, because we're going to see more and more of these. And your case studies, I think, are terrific, and I think they illustrate, the upside value proposition of AI. Just interested, for healthcare organizations, what is the time and effort involved? And if we're really going to scale this, are there some better practices, or can you made the point that data is sort of uneven in quality and that organizations are unique and you need a clinical champion. How can you scale from maybe one location to another, and what does it really take to get this really moving at scale?
No, great question. Boy, there's a lot there. So in order to, so timeline and effort. So if we're to deploy at a single organization, if you're looking at a specific disease area, I think naturally the data that you're looking to access within the organization is very nuanced and very specific to that disease area. And the time frame to develop a predictive algorithm is generally 3 to 4 months. Add on a couple more months for validation and then integration into workflow. To shorten that time frame, what we need to change to is getting access to all of the data, right? That's a very easy ask from Matt Hackenberg, but a big challenge for most organizations. If you give us access to all of the data, then we can develop more algorithms on a much larger data set. So that's speaking for one organization. In order to get to scale of predictive algorithms, you need copious amounts of data. I think that's a value proposition that IQVIA has, in that we've got the 1 billion medical records, patient medical records. When you develop algorithms on data sets that large, it tends to mean that they're representative of all of the potential geographies and areas that you're going to deploy in, because you've got data represented by all these organizations. So the idea is that if you're developing on a large enough data set, you don't have to deal so much with what we call localization, which is going to one facility into the next to refine that algorithm on site, because maybe there's something nuanced about their data or something nuanced about their population in general. The intent is build it on a very large data set that makes it easier to scale amongst organizations.
That makes sense to me. Matt, do you have some questions for us?
So we good? There we go.
There we go.
So there are a number of questions on the on Slido. The first one is more directed towards Matt. It appears that you're committed to transparent algorithms.
Yes.
Then how are you using generative AI, if at all?
IQVIA is so different team. I'll just give the context that different team within IQVIA, but the current space for us where we're looking at using generative AI is, let's say, consuming. We've been approached by several medical specialty societies, patient advocacy groups, who are interested in understanding all of the latest evidence that's available. Because it's very hard to keep up with what's best practice for managing, because the evidence is just constantly changing. So a use case in the generative AI is to go out and grab all of those research studies, use a Gen AI tool to produce a nice summary of here's what the latest and greatest evidence is doing. But generative AI has the opportunity to um, uh, chatbots, for instance. Think about the future where there's going to be dialogue with behavioral health patients and other patients that maybe are homebound. I think there's many, many opportunities out there.
We have lots, Helen.
Yeah,
so-
keep going.
Okay.
No,
Oh, the phone, of course, closed.
otherwise I'll fill in the gap, that.
So the next question was basically, why are you hopeful that AI-enabled CDS will occur, and what brings more value? EMR optimization or new AI CDS tools?
Great question. Great question. I'm very hopeful that our CDS tools trajectory will continue to improve. And I think the mention of Smart on Fire, right? What's the biggest challenge that we have today? If we want to develop on real world data, we need to have access to that EMR data. The challenge with EMR data is it's dirty, it's messy, and there's good pieces to it, but it is not always of high quality. And I think just taking a step back to large language models and the patient experience, I foresee that where large language models are able to consume EMR data and maybe put a summary in front of a clinician or a patient, there will be some concerns or will be elevated to patients of how bad some of the data might be, right? There's a mention of a disease that they had that maybe it never occurred or something that's erroneous in the EMR. The idea of generative AI and LLMs will now bring that to the front. And I think that there's going to be a period of time where patients are going to, there'll have to be a reconciliation, basically, where patients are going to say, this isn't right. This information needs to be corrected. And I think once we get over that hump, there'll be a future where the quality of the data is that much better. But the tools that are emerging for OMOP, for instance, where you can map clinical concepts to data standards, just keep getting better at the end of the day. So I think that there's still a place to get access to EMR data, run it through a future AI tool of some sort to clean it, but then deploy that back into the workflow as CDST.
So do you ever get to a place where you're using EMR data and because you had a project on social determinants and other social determinants of health data to paint
Yes.
more complex pictures? We know, for example, during COVID, that we saw multi-generational homes, for example, where COVID spread more quickly, that might not be as apparent if you just looked at income or something like
Yes.
that. So that context, I think, is really important. So marrying those data with the EMR data, and we started to collect in Ontario race-based data for the first time during the early parts of COVID, just to, again, really unpack this in a much more nuanced way than perhaps an EMR alone might do.
EMR data is inherently biased. It's biased towards those patients that are willing to interact
Right.
with the system.
Right.
So the answer to your question is yes. Do we use other sources of data, publicly available data, national data on social determinant health equity and claims data? I can think of another project. It's not by IQVIA, but the University of Pittsburgh, where they were looking at patients that were in the penal system that were likely to have an overdose, an opioid overdose, and they were able to pull in jail data, the incarceration data, which I thought was very fascinating, and it told a very interesting story.
Yeah, I bet you.
Yeah.
Okay, sorry.
Well,
Is anybody from this audience actually want to answer a question?
they would be asking through here.
Okay,
Yeah.
sorry.
But we're going to continue with the data because this is the most popular thing. So you just asked half of this question you just answered, and the other half is where does privacy play and where does health research play?
Yeah, great question. Privacy is first and foremost, right? Anytime that our organization is working with identifiable data of some sort, we need to have protocols in place, right? So if it's behind the walls of IQVIA, it has to be in a very secure environment that's aligned to HIPAA requirements, all privacy and security requirements. If it's a situation when an organization is willing to share their data, but it needs to be identified, there's opportunities to de-identify that information. There's tools, there's programs. IQVIA has a resource to de-identify and be able to share that information. Or it ties into a deployment method, right? Is it feasible to actually have the algorithm behind the firewall on premises, which is a methodology that we do follow depending on the comfort level that an organization has on security of the data.
So we're almost out of time. So I will leave any last question you may have, and then any last comments, and then all the questions that have been asked here this morning, I will forward off to the speakers, and they may feel that they can address it through social media or other means, that sort of thing. But they will get copies of your questions. So I will leave it with you.
Yeah, my last question was really around, because I couldn't help myself, on the funding model. We've experimented and we have in Ontario some examples of bundled payments. But do you think we need to sort of go all in as a support for some of these tools? Much of that work got, again, put aside by the urgencies of COVID. And as I've been sort of looking at this, I keep thinking, well, there's probably, a need to restart and recommit to really trying to, unpack the funding models and make sure we've got the incentives along.
Yep.
Would that be consistent with your thinking, and how important is it?
Yeah, absolutely. When we look at the funding sponsor, let's say is a life science organization, right? The primary requirement of ours is that everything is done above brand. So we're looking for opportunities where we could get funding for that work, but it cannot be focused on a particular molecule or anything like that. So that's life science. If it's government oriented, one of the requests that we usually have is making sure that we're building in the process and the measure to get access to the good quality data and do the NLP at the end of the day. So if you're funding to do some sort of quality measure around managing heart failure patients, I would say it needs to be inclusive of the natural language processing, because that tends to be an afterthought at the end of the day. And incentivize the organizations to do what's right for the patients. I mentioned it earlier that the fee-for-service in the US is killing us, in that I can find when somebody it could be prevented from going to the emergency room, or where they're not getting their medications filled. But in a lot of cases, it behooves a clinic to let that patient come in, let the bad thing happen, and then bill for those services. So a revamp of the funding model to show that the preventative services and embracing these patients with social determinant solutions, I think, is the way forward.
Great. Well, I'll hand it back to Matt. I get to have dinner with you tonight, so I
Oh,
for you
yeah.
with more questions, but
So,
Matt.
thank you everybody for joining. Really last point again with the people online. The people that are here now get a networking opportunity after hearing Matt's presentation. Those of you online will have to find another way to talk to Matt, but those of you here, enjoy the rest of your morning, and we'll talk soon.
Thanks.
Made with a plant-based cleanser designed for men's skin. Formulated with a vitamin and mineral complex, this formula works in harmony with your body to re-nourish dry skin. This 4-in-1 cold-pressed body, face, hair, and shaving bar is made with natural essential oils for smoother, healthier feeling skin. New Dove Men Plus Care Cleansing Bars. Click or tap now to shop.